Welcome back to the analysis of the facial beauty. In today's lecture, we will have time to summarize the general facial analysis items or standards used in the contemporary medical or plastic surgery fields. I'm sure you will be surprised that some items are not so much different as the traditional standards from long ago that we have learned from the former classes. First, skin quality. To analyze the skin quality, we are investigating four items. The first one is the skin type and complexion. The second one is skin texture and thickness. Third one is the photoaging. The last one is the severity of the facial rhytids. For analyzing the skin type and complexion, we usually use the Fitzpatrick Classification. This classification ranks the skin tendency to tan or burn after actinic exposure. The skin texture and thickness, we have concept as this. Total dermal thickness decreases approximately 6% per decades, and actinic exposure and smoking increases the rate of the dermal deteriorations. Regarding photoaging, Glogou Classification are used. This classification ranks the degree of the skin wrinkling and severity of photoaging. Finally, the severity of facial rhytids are classified into 5 grades. Grade 1, no rhytids at rest or on animation. Grade 2, the superficial rhytids on animation only. Grade 3, deep rhytids on animation only. Grade 4, superficial rhytids at rest, deep on animation. Grade 5, deep rhytids at rest, deeper on animation. When it comes to Fitzpatrick skin type classification, there are 5 types. Type 1 skin never tans, burns easily and severely, and extremely pale skin. Type 2 skin usually burns and tans minimally. Type 3 skin burns moderately and tans moderately. Type 4 tans moderately and easily and burns minimally. Type 5 rarely burns, dark brown skins. Type 6 never burns, dark brown or black skin. Moving on to the Glogou Classification. In this classification, there are 4 photoaging groups. Group 1 means the mild one and age from 28 to 35. It has a degree of skin wrinkling and photoaging as little wrinkling or scarring, no keratosis, and requires little or no makeup. Group 2 means the moderate, age from 35 to 50. This skin has early wrinkling and mild scarring, sallow color with early actinic keratosis. It requires a little makeup. Type 3. This skin has advanced degree of skin wrinkling and photoaging. It shows persistent wrinkling and discoloration with the telangiectasis and actinic keratosis. It always requires makeup. Group 4. This group of skin has a wrinkling and photoaging and gravitational, dynamic, and actinic keratosis with or without skin cancer. It requires makeup with poor coverage. There are classical Greek canons of proportion or formulated and documented by the Renaissance artists. These neoclassical canons are as follows, like in the screen. Number 1. The head can be divided into equal halves by horizontal line through the eyes. Number 2. The face can be divided into equal thirds with the nose occupying the middle third. Number 3. The head can be divided into equal quarters, with the middle quarters being the forehead and nose. Number 4. The length of the ear is equal to the length of the nose. Number 5. The distance between the eyes is equal to the width of nose. Number 6. The distance between the eyes is equal to the width of each eye. The face width can be divided into equal fifths. Number 7. The width of the mouth is 1.5 times the width of the nose. Number 8. The width of the nose is a fourth the width of the face. Number 9. The nasal bridge inclination is the same as the ear inclination. Number 10. The lower face can be divided into equal thirds. Number 11. The lower face can be divided into equal quarters. In addition to these 11 rules, the golden ratio of Fibonacci 1 to 1.618 is a common theme seen throughout the facial aesthetics. Okay, move on to the frontal view. When we examine the frontal view of the patient, we should remember the following rules and evaluate according to them. Vertical fibs, lines drawn adjacent to the most lateral projection of the head, the lateral canthi, and the medial canthi. As you can see in the screen. Horizontal thirds, lines drawn adjacent to the menton, nasal base, brows, at the supraorbital notch level, and hairline. The lower third can be divided into an upper third and the lower 2/3 by a line drawn through the oral commissure. The lower third can be divided into halves by a horizontal line adjacent to the lowest point of the lower lip vermilion. Horizontal line through the labiomental groove divides the stomion to menton distance into a 1:2 ratio. Widths of mouth and the stomion to menton distance are equal. Width of mouth approximates the distance between the medial limbi of the corneas. The width of the face at the malar level is equal to the distance from the brows to the menton. The distance from the infraorbital rim to the base of the nose equals the nasal base length, which is equal to half of the length of the middle third of the face. Okay, the next is the lateral view. When we examine the lateral view patients, we should remember the following rules and evaluate according to them. The face profile can be divided into horizontal thirds. The lower third can be divided into an upper third and lower 2/3 by a line drawn through the oral commissure. The distance from the mandibular angle to the menton is half the distance from the hairline to the menton. The desired lip-chin complex relationship is an upper lip that projects about 2 mm more than the lower lip. In women, the chin lies slightly posterior to the lower lip. In men, the chin is slightly stronger. Now move on to the region-specific analysis. Analysis of the region starts with the upper third, then goes to the middle third, then finally the lower third. The first is the upper third. In the upper third, there are forehead and upper eyelid and lower eyelid, and globe. The globe means the eyeball. Forehead. In the forehead, we should assess the proportion and contour. And we measure forehead height. It is a measure from hairline to mid-pupil. Fixed point rather than the hairline to brow. Then we assess for both active and passive frontalis, transverse forehead rhytids. And we assess for both active and passive corrugator, vertical, and procerus horizontal rhytid at the glabella. Regarding the brow position, we assess for compensated brow ptosis. The brow is ptotic but compensated for by frontalis hyperactivity. And we assess the medial and lateral brow position and the relationship of the brow to the upper eyelid. With lid closed, the brow should be 2 to 2.5 cm above the upper eyelid margin. At mid-pupil, the ratio of the aperture of the eye to the distance from brow to the lash line is consistent with the golden ratio as 1.618. The highest portion should be at or just lateral to the lateral third point corresponding to the lateral edge of the limbus in straight gaze. The medial portion of the brow should be caudal to the lateral portion. The greatest degree of brow descent often occurs at the lateral orbit, lateral brow holding. Let's continue with the upper eyelid. We should assess for redundant skin, skin quality, fat herniation, and soft tissue excess, such as subcutaneous fat, preseptal fat, and lacrimal gland ptosis. The normal intercanthal distance is 31 to 33 mm. However, 33 to 36 mm can be considered attractive sometimes. Intercanthal axis is normally tilted slightly upward from the medial to lateral. Lateral canthus is 2 degrees higher. Vertical opening is around 10 mm. Regarding the lid position, upper lid extends down at least 1.5 mm below the upper limbus, but no more than 3 mm. Pretarsal skin is visualized on relaxed forward gaze. Its amount is about 3 to 6 mm, and it varies with ethnicity. The distance from the lower edge of the eyebrow to the open lid center margin should never be less than 3 times the measurement of the visualized pretarsal skin. And supratarsal fold is 7 to 11 mm from lash line, and the indicator of the levator dehiscence is elevation of the supratarsal fold, accentuated supratarsal hollows. The woman shown in screen demonstrated classic signs of left levator dehiscence with ptosis, a high lid crease, and thinning of the lid above the tarsal plate. Going on to the lower eyelid, We should assess the redundant skin quality, right teeth, crow's feet, and tarsal laxity, skin pigmentation, as known as a blepharomelasma, festoons, fat herniation, tear trough deformity, and scleral show. The lower eyelid ideally covers 0.5 mm of the lower limbus, but no more than 1.5 mm. As a clinical tip, I can add the lid cheek junction must also be assessed and factored into the analysis because it is one of the more complex area of the face. The last one we should check on in this upper third area is the globe, as known as the eyeball. The doctor should determine whether positive, neutral, or negative vector relationship exists, and assess for globe prominence and proptosis in ophthalmos, exophthalmos, dystopia, visual acuity, and Bell's palsy. Okay, moving on to the middle third. In the middle third, we should check the nose, cheek, and ears. The nose has very many items to check. First, we should evaluate the skin type and texture. Thick and sebaceous skin does not drape as well, and edema takes longer to subside. Thin skin may drape too well and can show small deformities underneath the skin. Evaluate for deviation. A line drawn from the mid-glabella to menton should bisect the nasal bridge, nasal tip, and cupid bow. The width of the body of the nose at the nasal cheek junction should equal 80% of the alar base widths. The alar base width should be about the same as the intercanthal distance, which should be the same as the width of an eye. If interalar width is wider than the intercanthal width, determine whether it is caused by the increased interalar width or alar flaring. Normal alar flaring is white female is 2 mm wider than the alar base. If it is greater than this, alar base resection should be considered. If interalar width is increased, then the nostril resection may be indicated. The alar rims should flare slightly outward in an inferior direction. Two slightly curved divergent lines should extend from the medial supraciliary ridges to the tip defining points on the dorsum. When it comes to nasal tip evaluation, we should locate the tip defining points bilaterally, supratip break above, and the columella lobular angle below. These should form two equilateral triangles. And when we evaluate the columella should hang just inferior to the alar rims, giving a gentle gull wing appearance. From a visual view, an equilateral triangle is visualized with a 2:1 ratio of columella to lobular portion. The nostrils should be teardrop shaped. When we evaluate the nasal length, the ideal nasal length should equal the distance from the stomion to menton, which equals 1.6 times distance from the tip to stomion. Nasal length should be approximately 2/3 of the midfacial height, as known as the middle third height. Regarding the nasal tip projection evaluation, a line drawn from an ala cheek junction to the tip of the nose, when bisected by a vertical line drawn adjacent to the most projecting portion of the upper lip, should have 50% to 60% of the horizontal line anterior to the vertical line. If more than 60% of the tip is anterior to the vertical line, the tip is over-projected and should be reduced. If less than 50 of the line lies anterior to it, projection is inadequate and should be augmented. As a clinical tip, this relationship only holds true if the upper lip projection is normal. The nose tip projection equals the ala base width, and the nose tip projection should be approximately 0.67 times of RT, that is the ideal nasal length. This relationship also only holds true if the nasal length is correct. The next is the nasal dorsum evaluation. In women, it lies 2 mm behind and parallel to a line connecting the nasal frontal angle with the desired tip projection. A slight supra-tip break is preferred. In men, the nasal dorsum lies slightly more anteriorly. If the nasal dorsum is too far posterior to this line, augmentation will be required. If it is too far anterior to this line, reduction is indicated. Regarding the nasal tip rotation, this is determined by the degree of the nasolabial angle. Draw a straight line through the most anterior and posterior point of the nostrils on lateral views, where this bisects with a perpendicular line to the natural horizontal facial plane is the nasolabial angle. In women, 95 to 100 degree angle is preferred. In men, 90 to 95 degree angle is preferred. A nose with a high dorsum without a supra-tip break will appear less rotated than one with a low dorsum and a supra-tip break, even though the degree of the rotation is the same. The next is the columella lobula angle. This angle is formed by the junction of the columella with the infratip lobule. It is usually 30 to 45 degrees. Increased fullness in this area, usually caused by the prominent caudal septum, will give the appearance of the increased tip rotation even though the angle of rotation, that is nasolabial angle, is within normal limits. On intranasal examination, we should inspect airways, nasal valve, septum, and turbinates. And also, we should consider ethnic variations in nasal structures. Please remember, above-mentioned all rules are conformed to the Caucasian ethnicity properly, and the Asian might have another standards that we have to study. We should compare with nasal ideals for whites. The nose of black patients and those of Middle Eastern descent have the following characteristics. For blacks, wide, low nasal dorsum, and they have decreased nasal length and tip projection, and poor nasal tip definition is observed, and they have acute columella labial angle, and they have a big ala flaring. On the other hand, Middle Westerns have wide nasal bone and thick sebaceous skin and ill-defined bulbous tip, and high dorsum and over-projecting radix, acute columella labial angle, Slight eyelid lining. Okay, now let's move on to the cheek. In cheek area, we should assess the right teeth, lid-cheek junction, volume of the facial fat, descent of the malar fat pad, and a skeletal proportion. A useful face has high cheekbones with concavity in the buccal area. Next is ear. Normal ear aesthetics have these characteristics. The ear is positioned approximately 1 ear length posterior to the lateral orbital rim and centered in the middle towards the horizontal plane. Long axis inclines posteriorly around 20 degrees from the vertical line. Width is 55% to 60% of the height. Anterolateral aspect of the helix protrudes to 21 to 30 degrees. It might be 1.5 to 2 cm from the scalp. Helix should project 2 to 5 mm more laterally than antihelix in frontal view. Okay, finally, the lower third. The lower third have important structures such as mouth, chin, and neck. First, the mouth is considered. We should assess the dental occlusion. Regarding lips, we examine key landmarks including vermilion cutaneous junction, cupid bows, and philtrum columns, and assess for presence for perioral retids. Assess for volume loss, and assess lateral angle of the mouth, aging lower this and causing downward slant. We should measure upper lip length. At rest, with the lips slightly separated, the upper lip should expose approximately 1/2 of the incisor teeth. Nasolabial groups and the marionette lines from the corner of the mouth to the mandibular border. Assess the depth at rest and during animation. Chin. In chin area, we should assess projection in relation to the other facial proportions. Pogonians should be 3 mm posterior to the nose, lip, chin plane. Nasal length, ideal nasal length, as known as RT, is equal to the vertical chin length. The radial plane is line touching projected lips should touch the pogonion. Assess the labiomental group definition, which should be approximately 4 mm deep. Moving on to the neck region, we have to assess the skin for quality, tone, excess, and right teeth as usual. Evaluate for subcutaneous and pre-platysmal fat. Assess for static or dynamic platysmal banding. And we should look for some mandibular gland ptosis. Regarding mandibular cutaneous ligament, we should remember tethering of the descending facial teeth at this ligament produces the appearance of jowl. We can say the quality of useful neck as distinct inferior mandibular border, subhyoid depression, visible thyroid cartilage bulge, visible anterior border of the sternocleidomastoid, and finally, cervical-mantle angle of 105 to 120 degrees. Finally, I can give you some important issues to be stressed. Number 1, skin quality will dramatically affect the result. Number 2, please consider facial relationships both from static and a dynamic standpoint. Number 3, it is equally important to look at both the individual parts of the face as well as the face as a whole. Number 4. Preoperative counseling is imperative. Areas that will not be addressed should be pointed out to patients so that they can recognize them and accept that they will be present postoperatively. Number 5. These are only guidelines. Many aesthetically pleasing faces do not have these proportions. These assessments are useful in determining factors that are responsible for individual appearance. Number 6. Ensure that what a patient wants is congruent with what you, the surgeon, can do. It is acceptable to say no. Okay, this is the end of today's lecture. Thanks for tuning in and see you next week.